So this afternoon, I'm excited to have Sarah Richardson join us to discuss physical therapy approaches to oncology care beyond lymphedema. So our presenter is a highly accomplished physical therapist with a diverse educational background and extensive clinical experience. She earned her doctorate of physical therapy at UNC Chapel Hill in 2021. She also completed a women's health residency specializing in oncology and pelvic health at UPMC in Pittsburgh, Pennsylvania. And currently, Sarah serves as a physical therapist at UNC Health, operating in an outpatient setting where she treats pelvic health conditions and oncology patients. And she teaches future physical therapists at both the University of Pittsburgh and UNC Chapel Hill's Doctorate of Physical Therapy programs. So welcome and thank you, Sarah, for being here. Outside of your professional bio, anything else you'd like to share with our audience?
I would say a fun fact about me is I am obsessed with like cooking competitions. So I've probably seen like on TV all of the available cooking competition shows. Guy Fieri is like, I think my favorite television personality ever. I watch all of his shows. I've probably seen most episodes, which is maybe embarrassing because there's a lot, but that's like, if I'm going to watch TV, I love watching people cook and compete. So
do you cook and compete yourself?
I do not compete. I love cooking. I could never do what people do on that show, but I think it's so creative cooking, and I'm always amazed at what people are able to come up with. I can cook without a recipe, but that's my only claim to being decent in the kitchen. So definitely not competitive worthy, but admire them.
That sounds great. Thank you for sharing. So for our audience, this is a sample of what the poll everywhere question will look like. You will have a chance now to go and practice. So go to pollev.com, enter UNCLCN. You could also join by your smartphone and get set up for poll everywhere. Here are our disclosures. And our first practice question thank you for participating. Cancer and cancer-related treatments can cause physical impairments. So Sarah, how'd they do with our sample question?
Beautiful. Great start.
Thank you. So I will now turn it over to Sarah. Thank you, Sarah.
Thank you. So again, I wanted to do this presentation to share a little bit about the role of physical therapy in oncology care. And although I'm a certified lymphedema therapist, I want to kind of gear towards other things that we could be of support to your patients with beyond just lymphedema, because there are a lot of other impairments that patients may experience that a physical therapist could support with. So here are some of the objectives for today. So identify some of those physical challenges that patients with cancer may experience beyond just lymphedema. Discuss the role of physical therapy in survivorship care plans. Explain the relationship of evidence-based physical therapy interventions and how they may improve patient outcomes, as well as describe and talk about the interdisciplinary collaboration between healthcare workers and physical therapists to help deliver optimal cancer care. And I just want to preface, there are other providers and other therapists, such as speech therapists, occupational therapists, that also have a role in supporting cancer patients. However, as a physical therapist, I'll speak from my experiences and my role and scope of care, but I just wanted to acknowledge that I recognize there are other providers that could also assist with some of the impairments that I may go through today. And I have in the past often collaborated with those providers to create kind of more collaborative care for patients when they may have impairments that extend beyond physical therapy. So the first couple of slides will be kind of review or discussion of common side effects that patients may experience because of cancer treatments. So some very common ones on the screen that also physical therapy could support with are pain, changes in sensation, blockage in the lymphatic system, muscle weakness, joint stiffness, fatigue, loss of endurance and strength of muscles, loss of bone density, more challenges with their daily living activities, moving, walking, those transfers, bed mobility, and impaired balance, as well as some heart changes or shortness of breath and breathing difficulties during activities that maybe didn't bring on those symptoms before. Some other side effects people may experience as well would be trismus, so reduced mouth opening, especially in those that have experienced head and neck cancer, genitourinary dysfunction for those that have experienced genitourinary cancers, as well as kind of muscle shortening and contractures depending on the type of cancer and the treatments that they've received. And we do have and have experienced advances in cancer diagnosis and treatment, along with growing and aging populations, which has led to more and more cancer survivors worldwide, which means that there's a lot more people that are living with wide-ranging side effects from cancer and its treatments. These side effects can be acute, long-term, or late occurring, but they all can impact a patient's quality of life in physical and psychosocial domains. So I think a lot of times we think of physical therapy as reactive. So someone develops an impairment and then we refer them to physical therapy. However, physical therapists and rehab providers, we can help patients prior to initiating some of their cancer treatments or prior to surgery, because some of these individuals may have existing impairments and would benefit from a screening and education prior to some of their treatments, as well as kind of follow up afterwards if any impairments change from some of the treatments that they've been receiving. So diving a little bit more into the side effects from radiation therapy specifically. So of course, we can have more early side effects that can occur during, immediately after, or soon after radiation treatment that are often reversible. But patients may also experience later side effects, which can occur several months or up to years after radiation therapy, which tend to be more chronic and progressive in nature. And on the slide, it's kind of divided into different types of cancer and the common symptoms that they may experience in response to radiation therapy. Now, certainly, physical therapy can't assist with all of these side effects, but there are a lot of commonalities just depending on the location that the radiation is provided. And we do have a role and can be supported in a lot of the common impairments that people may experience. So particularly swelling, skin changes, pain, as well as more for the pelvis and the rectum. So genitourinary cancers, we can have a role in helping restore sexual function, bladder function, bowel function, and give resources and strategies so that they're able to manage those symptoms that can certainly impact the quality of life. Now, this slide, this is a chart from a research article. Granted, it is several years old. It was from 2015, but this was a retrospective chart review that was done. They reviewed patient charts of about 418 patient charts that all received physical therapy care in the University of Florida Davis Cancer Center. And basically what they were looking at is what kind of cancers patients were coming in for physical therapy, as well as what kind of treatments they had received already or were going to receive during their plan of care with physical therapy. So in this chart, you can see on the left-hand side, it's all the list of different cancer diagnoses that patients were seen in physical therapy with. As well as towards the right-hand side, you can see the percentage of patients of what kind of treatments they had already received or were receiving during their PT plan of care, divided into chemotherapy, hormone therapy, radiation therapy, and then surgery. The most common types of cancer that was seen by a physical therapist was breast cancer and genitourinary cancers. But taking a moment, you can kind of glance at this chart and see just the different distinctions between treatments that patients had or were going to receive when they were evaluated by physical therapy. And then at the very bottom, it just has kind of a summary of percentage of all of the patients with a cancer history and who had undergone those various treatments. Now, on this next slide, this is from the same article, and now this is outlining, based on the different types of cancer, the different musculoskeletal or neuromuscular impairments that patients were experiencing at the time of their physical therapy evaluation. What is in bold here is anything that it was above 50% for complaints or impairments found in these different patient populations. And it makes sense with some of the different percentage of treatment options, why some of these patients with different cancer types would experience different kinds of symptoms. But still, if you look at some of these categories, for example, if we look at the breast cancer category, 79.4% were experiencing postural changes, 85.3% had range of motion changes, 94.1% noticed changes to their soft tissue structures, 82.4% had impact to their strength, 66.2% had developed lymphedema, and 69.1% had pain. And you can see a lot of these individuals have lots of symptoms that they're maybe experiencing that could drastically impact their quality of life. And then at the bottom, you can see kind of in that third row from the bottom, the number of physical therapy sessions on average that patients completed within their plan of care. So certainly depending on, it seemed that the more impairments or symptoms someone had, the longer that a plan of care was expected for. But I do think it's helpful to look at this, although this was from 2015 and in a different area. It's not uncommon for physical therapists to be seeing these patients, and it's important to kind of keep in mind the different impairments that may be impacting their quality of life that they're seeking PT services for. Alrighty, so this is our first official poll everywhere question. So it's kind of a 2-in-1, so you can answer both. But what are common side effects of cancer treatments? And what side effects could rehabilitation or physical therapy support with?
While we wait for some responses to push through, I know working in GI oncology and especially in rectal cancer, so pelvic floor complications, some are coming in now.
Good, the 3 I'm seeing on the screen so far are correct. Pain, skin changes, mobility, fatigue, shoulder range of motion. And I would say range of motion for other joints as well, but certainly with breast cancer, we see shoulder range of motion a lot. Fatigue and pain, yep. Good, loss of sensation, yep. Reduced range of motion of the radiated area. So strength changes, swelling, and lymphedema. Yep, joint changes. Good, yep, so genitourinary symptoms, so bladder dysfunction. Neuropathy. Good. Okay. Awesome. So all of those were accurate. Yep. Okay. So, I do want to acknowledge moving forward that there are certainly barriers to incorporating physical therapy services into a plan of care or into a patient's care. This was an interesting study. It was basically a qualitative study that had semi-structured interviews, and they spoke with physical therapists that worked in a cancer care setting to see what they found were barriers for physical therapy intervention in those that had cancer. So some of the barriers, which probably extend beyond just physical therapy, but to a lot of our professions and the work that we do. But one was certainly a need for more services. There are a lot of variety of services provided, and certainly as we have more cancer survivors, there's going to be an increased need for providers to work with these patient populations. And also they acknowledge that there are inconsistencies in the services that are offered kind of globally, particularly, regionally as well, and that there's often sometimes disjointed or differences in the care models in different hospital systems. Another barrier that was identified by physical therapists was barriers to service development and delivery. And what they meant by that was certainly, I think all of healthcare has felt this, but lack of funding for newer positions, needing more resources for patients and providers, and difficulty protecting the current services that exist because of lack of funding. Another barrier that was identified was lack of awareness of the role of physical therapy. So some of the therapists identified that oftentimes physical therapy may not be thought of as one of the providers to include in that multidisciplinary team. But there's also a lack of awareness with patients. I've had a lot of patients that come to me and they say, oh, I didn't know I could go to physical therapy for this, or I didn't know this was something that physical therapy could treat. So certainly I think it's not just from a healthcare understanding, but I think from a patient and general public understanding that there's a lot of nuances of things that physical therapists can support with, but often physical therapy, the first perception is maybe more orthopedic settings or post surgeries like knee replacements and hip replacements, but there's a lot of different varieties of physical therapy out there, and there are a lot of things that we can treat that maybe extend beyond the current knowledge of what PT is. Another thing that they noticed was facilitators to service development. So a lot of times the medical teams are a key source of support, as well as needing support from management and aligning with local and national goals. So a lot of times there's best intentions to include different services, but of course, there's lots of barriers as to why sometimes referrals aren't placed, or also patients don't end up going to the referrals that are made. Another barrier was priorities of the future of oncology physical therapy. So they kind of noted that there are not a lot of national standards for physical therapy in oncology patients. And there is not a huge emphasis. It is growing, but in our national organizations, there's not a huge emphasis on the cancer rehabilitation part. There is a special interest group, but it is small comparatively to some of our other established interest groups, such as sports or pediatrics. So it is a growing field, but part of that is a barrier, there's not a lot of therapists that necessarily treat in this population consistently. And lastly, training needs. Certainly this is a particular population and there's an important understanding to work with these patients safely. And that requires, resources, continuing education, and all of those things that further take time and other resources for therapists. So just wanted to acknowledge there are barriers for PT inclusion on a multifactorial space. Now, there's also barriers for physical activity participation from cancer survivors themselves. So one study found that about 20% of cancer patients who have undergone treatment are not meeting the daily physical activity guidelines, which is 30 minutes of moderate physical activity 5 times a week. And we're aware that physical activity has a lot of benefits. It can support physical and psychological symptoms that are associated with cancer, but there's a varying level of awareness of that benefit amongst patients for that psychological and physical health. And it is multifactorial why patients aren't meeting those physical activity recommendations. But it was found that without having a recommendation from an oncology clinician or a provider in their care team, that's a known factor as to why individuals aren't meeting those physical activity guidelines. And additionally, a lot of patients don't exercise, and I've heard this a lot, is they didn't know what was safe to do. There's a lot of concern of, I don't want to hurt myself. I don't want to make things worse. I don't want to, delay my healing. And so a lot of patients just stop moving altogether, which can lead to more challenges than getting back to their previous activity levels. So this article had recommendations for providers that work with cancer patients often, and they recommended the assess, advise, refer method. So viewing physical activity as a vital sign and including it as a question for every patient that you see. And if a patient's not meeting the physical activity recommendations, to ensure that you educate on the importance of meeting those guidelines, that it can impact their function and their mental health. And then if you feel like the patient needs support and guidance, to refer to the appropriate providers to help establish that exercise routine. So this is from that article. So it had kind of a guideline of strategies of how to refer and how to ask those questions. So the first step, again, is to assess. So they recommended asking 2 questions. The first is, how many days during the past week have you performed physical activity where your heart beats faster and your breathing is harder than normal for 30 minutes or more? And the second question being, how many days during the past week have you performed physical activity to increase muscle strength, such as lifting weights? Based on their answers to that, will help guide if you feel like they may need support or education to increase their activity levels. The last question that they recommend is not one that you ask the patient, but that you ask yourself. Would this patient be safe exercising without medical supervision? And if the answer is yes, then again, you can advise them with those recommendations and then refer them to a community program. There's a lot of great exercise community programs in the area, whether it's, for example, Get Real and Heal, or the Live Strong through the YMCA, for example. But if the answer is no to yourself, I don't think they would be safe exercising without supervision, or I don't know and I don't have the capacity to evaluate that at this time, then you can still advise and recommend and put in a referral to a physical therapist or other rehabilitation provider so that they can make their recommendations and kind of support that patient in getting back to their physical activity levels. Or if they're not a candidate for PT, then help them establish connection with some of those community resources. And then this was also from the article, but just kind of outlining that it's not kind of a one and done. Evidence supports that, supervised exercise leads to better outcomes than just exercising individually. And, oftentimes maybe someone goes to physical therapy, but then they need to transition, aren't quite ready to go to self-directed, and then that communication between can be helpful. I've even had from some participants in Get Real and Heal, they've had the leaders of those groups reach out to me because they've noticed that, oh, this participant is having more challenges. And then there's been a back and forth, and I've had some from that program then come back and work with me in physical therapy, or vice versa. When someone does well in PT but isn't quite ready to exercise on their own, they can transition back and forth. And it is important, not just asking once, but when you see these patients in follow-up, that we touch base with these again and kind of ask those questions in regular intervals, because often that reinforcement and repetition is what's going to lead to patient change, as opposed to mentioning it once. Likely it's not something that a patient will invest in most cases. And also, I just want to highlight, it's not expected that, oncology clinicians are providing, exercise prescriptions, but more to have that role in educating our patients the importance of exercise and why it may help with some of those impairments that impact their quality of life that come with their cancer treatments or diagnosis. Alrighty. So our next poll everywhere question is another open-ended one. So what are potential barriers for including physical therapy within oncology care? And that could be from a patient standpoint or maybe from a provider standpoint. Good. So lack of awareness of existing services, definitely the cost to patients, absolutely. Good, again, lack of knowledge. Yep, certainly from a patient standpoint, transportation barriers, time with all of their other medical appointments. Yes, insurance limitations, absolutely. Lack of access. Definitely, I've had patients that have had to travel a long way for appointments because they don't have services nearby. Yep. Time management during treatment. Yep. Fear. Yep. Yep. And access to, as well as kind of wait times for appointments. Yeah, patient has medical appointments to coordinate, especially if someone's, in the middle of their cancer care. There's a lot of appointments that they have to attend, and it can feel overwhelming to add another person that they're seeing on a regular basis. Yeah, and I think it is important to recognize that there are lots of barriers for patients and for providers on that standpoint. And I appreciate what you all lifted up, especially insurance and transportation. That certainly impacts frequency of visits, and being able to see a patient consistently, as well as how far they're traveling. Those are important things to consider when sending a referral and establishing that plan of care. Alrighty. So diving a little bit more into the role of physical therapy and rehab in oncology care. So this was actually kind of a larger systematic review that looked at clinical practice guidelines for oncology care. And what they found is 32 of the 69 guidelines for various cancer diagnoses recommended a referral to physical therapy for an assessment, and they even outlined what should be included in the physical therapy assessment and intervention recommendations for a variety of cancer types. A lot of the cancers that were included in some of those stronger clinical practice guidelines that had more specific recommendations included breast cancer, prostate, head and neck, lung, thyroid, hematologic, esophageal, as well as just general survivorship across all cancers. But the remaining guidelines, although they weren't as specific, did endorse the importance of rehab referrals, but didn't provide specific recommendations for what to assess and treatment options. Some of the clinical practice guidelines included societies such as the National Comprehensive Cancer Network or the National Institute for Health and Care and Excellence. And I think a major theme that was found with this is recommendations for rehab services were pretty prevalent amongst a lot of the oncology guidelines. But what they found and what they noted is that there is a high functional morbidity burden associated with cancer treatments. And it's estimated that at least 60%, if not more, of individuals that are living with or beyond cancer are experiencing significant impact to their quality of life and daily living. But only 20% of those individuals are referred to rehab services for cancer treatments. So just wanting to bring that up again, that over 60% are maybe experiencing these impairments that we've previously talked about, but only 20% are being referred to physical therapy. And as we kind of talked about, or you put in the polls, there's lots of barriers or potentially reasons for that, but that's a big disparity between how many patients are experiencing significant morbidity and how many are being referred. And then on top of that, likely, of the 20%, not all of those are pursuing physical therapy for some of the barriers that were outlined and shared. And there's no, comprehensive rehab guideline that, states this is the perfect way to do things. But, I think it seems from this article that we are kind of falling short to really address the totality of our patients' needs. So on the next couple of slides, I'm going to dive into a little bit more patient populations that I work with most often and some PT interventions that we often provide for patients within this. So I won't talk about all types of cancer, but kind of focus a little bit more on what I most commonly see and work with. So the first would be head and neck cancer. So on this slide, there are a few common impairments that I tend to see clinically. The first is spinal accessory nerve palsy. The next is shoulder dysfunction, trismus, which is reduced mouth opening, and then lymphedema. So again, not going to dive into lymphedema as much, but talk about the first couple here. And trismus, for this purpose, was defined as kind of mouth opening less than 35 millimeters, or another way that they defined it was the 3-finger test. So if you use 3 fingers opening the mouth, if you're able to comfortably insert all 3 fingers into your mouth, that's considered enough functional mouth opening to do most activities. If they weren't able to do that, that constituted as trismus. So as you can see in one of the survivorship care guidelines, that for most of these impairments, it is recommended to include physical therapy for at least a baseline assessment to support with some of these symptoms. So this is one randomized control trial looking at the impacts of progressive resistive training for those that experience shoulder dysfunction after head and neck cancer. And they did find that compared to just traditional physical therapy or traditional exercises, that the progressive resistive training improved shoulder pain and dysfunction in patients with head and neck cancer more significantly. This is kind of showing in here just an example of what that can look like. So using various forms of resistance and working on different range of motion, and really a lot of kind of scapular stabilization is what we typically focus on for those with shoulder dysfunction, especially if they also have any nerve involvement, where we're wanting to stabilize the scapula as much as we can to allow them to be able to use their arms fully. And this can also, that gradual resistance can assist with reduction in pain levels too. This was another randomized control trial looking at different scapular strengthening exercises and more motor control focus for patients with head and neck cancer with shoulder dysfunction. And they kind of looked at how this would impact the range of motion as well as pain levels in the shoulder. And so I wanted to include just some of the examples of what some of the exercises that this group included. So again, really kind of focusing on a wide variety of shoulder stabilization exercises, but also some motor control principles, such as with the push-up press, the wall slide. So scapular activation, but also controlling the way that we're moving our shoulder, not just trying to reach overhead, but making sure all of the muscles that support that smooth movement are contracting as well. Now moving on to trismus, so again, that reduced mouth opening. There are benefits of including manual therapy for those that are experiencing trismus. A lot of times, unfortunately, they begin to experience trismus, especially after radiation. It just leads to a lot of fibrosis and shortening of some of the muscles in that area. And in most of the research that I looked at, the randomized control trials, is they saw the largest gains in degrees of mouth opening after the first treatment with physical therapy, but there continued to be modest gains with serial treatment. Often just physical therapy alone will not be enough to support them. So typically it's enhanced with manual therapy, but combined with passive stretching. So I've included a device that we often coordinate with care teams for patients to use, or something similar. It's called a TheraBite. So it's basically a device that can help introduce that passive stretching to the joint and the muscles. So I often instruct people through this, and then also do hands-on techniques. So in that center picture there are muscles within our mouth that we can get to intraorally, and almost like massage techniques, trigger point release, we can apply pressure and help encourage mouth opening to the pterygoids. We can also do techniques to the masseter, as well as some of our surrounding muscles that can help with pain as well. And again, exercise therapy can enhance mouth opening, but it doesn't necessarily prevent trismus, but can help restore mouth opening or maximize it as much as we can. There wasn't really a clear consensus in the articles that I looked at for the ideal intervention, but the systematic review that I looked at did find that a variety of different exercise regimens and jaw rehab devices had comparable effectiveness. And the last kind of picture here on the bottom right, we not only can help with the muscles, but there are jaw mobilization techniques that we often implement to help the TMJ joint open up more fully. So we use a kind of combination of exercises as well as manual therapy. And I've had a lot of success with patients in my practice, kind of this multimodal approach. And I will say for trismus as well, I often include or work with speech therapists who are working on other symptoms that patients may be experiencing related to more swallowing challenges. And often working together, we can kind of help the patient with multiple goals they may have. Alrighty. So there's also treatment options from a PT standpoint for cancer-related fatigue and neuropathy. So fatigue, a lot of you mentioned that as a really common symptoms that patients experience. That is the most experienced symptoms by patients and cancer survivors. Almost all patients who undergo treatment for cancer will report that fatigue, and about 50% will mark it as severe. And exercise is where it is a helpful intervention for improving fatigue, but there's also other benefits such as cognitive improvement with their sleep, mental health, pain, as well as musculoskeletal dysfunction. And in some studies, they find that when you work on the aerobic capacity of patients, so including aerobic exercise, even just 10 minutes a day, but up to 45 for several months, that it can lead to a lot of improvements long-term in some of the psychosocial as well as physical impairments that patients experience. It's also been found that resistance training can be helpful for fatigue as well. So one study found that just 2 sets of 8 to 12 repetitions, doing that 3 times a week, led to improvements both in upper and lower body strength compared to usual care alone. And these people were undergoing chemotherapy. And they also found, interestingly, that the group that went through resistance training while undergoing chemotherapy were able to tolerate higher relative doses of chemotherapy with less side effects. Also, resistance training can help with bone mineral density when combined with plyometrics, which is another concern depending on someone's cancer treatments. And when it's combined with aerobic training, this was interesting. In one study, it was only 4 weeks for an intervention of aerobic and resistance training, but in just 4 weeks, there was improvement in their reported fatigue levels, reported quality of life, and sleep. So as well as with kind of numbness that was more fatigue, but certainly there is a lot of opportunity to support patients' balance and their strength, which can help with the risk of falls if they have developed neuropathy. So this is just kind of a summary of the exercise guidelines for cancer patients and survivors, which is similar to what a lot was seen in some of those studies, what was implemented. So it is recommended that they meet that 150 minutes of exercise a week of moderate intensity or 75 of vigorous. Do resistance training 2 to 3 times a week, as well as flexibility exercises. I do want to acknowledge, certainly depending on someone's response to their cancer treatments or prior physical activity levels, someone isn't likely going to be able to maintain this, or if they weren't physically active, you're not going to go from 10 minutes a week to 150, but introducing that gradual increase in activity levels could be beneficial for patients long term. Alrighty. So I also want to acknowledge, I am a pelvic floor physical therapist as well. So we can have a role in supporting patients that are noticing any genitourinary symptoms after cancer in this area. So some things that we can treat and support are pelvic pain, urinary incontinence, whether that be stress urinary incontinence, so leakage with cough, laugh, sneeze, or pressure events, or urge incontinence, so leakage with that sense of needing to use the restroom. We can assist with constipation, with fecal incontinence, and how we do this is through exercise prescription. There's manual therapy or hands-on techniques, behavior modifications, and then patient education. So PT can often be helpful, especially in gynecologic cancer survivors who develop dyspareunia. So there are shown benefits from participating in pelvic floor physical therapy, which can improve pain, sexual function, and pelvic floor dysfunction symptoms, which do include urinary incontinence and fecal incontinence. Physical therapy also can be helpful in those with prostate cancer. The 2 most common side effects are typically urinary incontinence and erectile dysfunction. But there's been a lot of research that's shown that inclusion of supervised pelvic floor physical therapy or pelvic floor muscle exercises is beneficial and can lead to reduction in urinary incontinence compared to not supervised. And a lot of times, in my experience, I don't often have to work with these patients long term, but it's been shown that there's a benefit in having a patient who's going to undergo surgery for prostate cancer see a pelvic floor PT prior, because some people don't quite know how to do a pelvic floor muscle contraction properly. And sometimes just seeing a therapist once before their surgery allows them to know how to efficiently strengthen this muscle to work on that in the post-op period. And again, as I kind of said, that usually they found that supervised pelvic floor muscle exercise training can lead to reduction in urinary incontinence rates, especially when it's done preoperatively compared to non-supervised. And again, I think that a lot of what I've seen is people, it's muscles that we can't see. And so a lot of people just need a little bit of support in learning where those muscles are and how to contract them. And it can lead to a lot of improvements without a lot of visits. It's just sometimes that little bit of incorporation prior to surgery gives them a lot of strategies and things that they can work on after surgery. So another thing that I've seen more recently in my practice is I have treated a lot of patients who have breast cancer related impairments, so range of motion or pain with their upper body, but then share with me that, I'm noticing kind of some more challenges with other things, and just with that comfort level, I've had a couple of patients that I've seen for more breast cancer related impairments, so range of motion, but share with me because of their treatments or medication regimens that they're noticing more pelvic floor symptoms. So genitourinary syndrome of menopause is a collection of signs and symptoms associated with the reduction in sex steroids, which usually involves kind of tissue changes to those structures in the perineal area or in the vulvar area. It is commonly experienced in breast cancer survivors, especially those receiving anti-estrogen therapy. More than 60% of postmenopausal patients with breast cancer will report vaginal dryness and pain with sexual intimacy or dyspareunia. And often it's recommended, moisturizers can be helpful, lubricants, but pelvic floor physical therapy can be helpful for these patients as well. And dilator therapy, but it's helpful for a PT to kind of help patients through that. And it has been shown to be effective in treating urinary incontinence, prolapse, as well as relieving some of these symptoms. So, if you're working with people and they do mention these things are coming up, it may be worthwhile sending them to a physical therapist to help beyond just lubrication and moisturizers. They may need a little bit more support for some of those symptoms that they're noticing with their cancer treatments. Alrighty. So I did want to briefly talk about lymphedema since that's also what I treat, but again, not the main emphasis. But not everyone that has breast cancer or breast cancer treatments develops lymphedema, but it is everyone is at risk, if they have lymph nodes removed. And even those with a sentinel lymph node biopsy, some research has shown that from 0 to 63.4% of patients will develop lymphedema in 12 months following that. So, we do think about more that axillary lymph node dissection with radiation, that those are higher risk levels, the more lymph nodes that are removed. But, even with just 1 or 2 lymph nodes, patients still are at risk for developing this. It was interesting, this study looked at incorporating resistance exercise around the time of their treatments, and they actually found that participating in resistance exercise, there was no difference in the rate that lymphedema occurred, but they did find improvements in muscular strength, and in some cases it reduced. So certainly strength training didn't worsen lymphedema onset and helped with more their function of their arm. And it is recommended to include early postoperative exercise. And in some studies, they recommend using an upper extremity compression garment in those that are at risk, just to kind of support their limb in their recovery. And they also recommended progressive resistance training at least 1 month post their surgery. But even if someone's at risk, it's helpful to maybe even see a physical therapist just for a baseline evaluation, give these strategies. And I've even seen people I don't have follow-ups with, but they wanted to come in and get information. I give them strategies and exercises, and then they're able to continue on. And of course, a lot of our breast cancer folks do experience what was shared in the poll everywhere, changes in our range of motion, skin integrity, especially in the area that they've had surgery or radiation therapy. So one randomized control trial looked at physical therapy in the post-operative period after a mastectomy, and they did find that there were improvements in shoulder range of motion, reduction in pain, and improvements in functional disability. And so you can see kind of on the pictures on the right, that's an example of some of the exercises that were included. And then scapular strengthening, along with typical PT treatment, can also be helpful for those that are experiencing shoulder range of motion changes, and kind of seeing that wall slide is an example of what a scapular stabilization exercise could look like. Alrighty. And the next that I've been seeing more and more of in my clinical practice is cording or axillary web syndrome. So it's thought to be kind of cording of the lymphatic system. So a rope-like structure that develops mainly under the axilla, but it can extend to the medial aspect down the arm, but I've also seen it extend down to some people's wrist. So physical therapy can be helpful for this, especially those that are noticing significant pain or challenges with their arm motion from this. So it can help with that shoulder function, pain, and quality of life. And often we can see improvements if they have lymphedema as well, in cording just from manual lymphatic drainage as well as some stretches. Typically, the recommendations are including stretches to help open up the chest wall and to stretch the area where they're noticing the cording, but also manual therapy techniques. So manually stretching the cords, doing release techniques, just passively stretching their arm can be helpful for many patients. And on the right is just some examples of what that may look like or present like. Great. So our next poll, what side effects of cancer treatments could be enhanced by the inclusion of physical therapy within their care? So not lymphedema, but what are some other side effects of cancer treatment or impairments that physical therapy could be of support for? Trismus, pain, bowel and bladder dysfunction, good incontinence, range of motion and strength, general mobility, fatigue and reduced endurance. Skin integrity, balance, yep. Yep, sexual dysfunction, good activity tolerance, balance, good. So to our last couple slides here. So to kind of outline again the role of physical therapy in oncology care. So cancer survivors are almost 3 times more likely to report fair or poor health after treatments, and twice as likely to have psychosocial disabilities and physical and functional limitations as people compared to people without cancer or chronic illness. And again, just bringing this point up is I think a lot of times rehab is considered to be more reactive in nature. So someone develops symptoms and then goes to PT to try to reduce the symptoms that they develop. But I think the point of cancer care or cancer diagnosis offers a unique opportunity to identify the individual's baseline function and performance and establish a plan of care to prospectively monitor that function throughout their treatment. So physical therapists could have a role sooner on, even just to establish a patient's baseline and follow up as needed. But that may make a world of a difference if there are existing impairments and things that they could get support for prior to initiating some of their treatments so that they can reduce those impacts to their quality of life. And again, just bringing back up that statistic that more than 60% are experiencing significant life burden from some of their impairments, but only 20% are being referred to providers that could help with the quality of life. So again, I know there's lots of barriers that we talked about as to why sometimes one, we're not able to refer patients or patients aren't able to attend therapy consistently, but I still think there's an opportunity to enhance the care and include physical therapy to help support some of those quality of life symptoms that maybe don't have the time or capacity to treat in other ways. And the last thing that I'll go through is communication with patients. So certainly when it comes to kind of chronic disease management and health behavior change, that, both of these things need to be done by and with the patient. And patients who participate in their medical decisions often have more enhanced outcomes. They tend to have higher levels of satisfaction with their care, have more knowledge about their conditions, have more realistic expectations about the benefits and harms of treatments, and are more likely to adhere to recommendations. I think if patients are not aware of services or the benefits of services, they're likely not going to pursue those things. And also, if they're not told that these services are available, they're not going to know that it's something that they can pursue treatment for. A lot of times patients may be experiencing side effects and symptoms that they're not sharing because they're just not aware that it's something they could have support with and think it's something that maybe they just have to live with. So, at least with the UNC system, so there are certainly other lymphedema and therapists in the area. It's not just through UNC, but if you did have a patient that you wanted to send to physical therapy at UNC, this is just a screenshot of how to go about that. But again, there are lots of other providers outside of UNC that do this kind of work, but the goal is just for us to be included and kind of coordinate patients to advance their care. And then these are some of the resources. So thank you.
Thank you, Sarah. That was really informative. Thank you for sharing your expertise. And to our audience, you may submit questions for Sarah through Poll Everywhere. We have just a couple of minutes before wrapping up. Sarah, as we wait for questions to come through, one of your last slides bring up a really good point and challenging point, and that's behavior change. So there are times my interactions with patients are they went through physical therapy and then you talk with them about maintaining and continuing what was recommended by the physical therapist or doing those exercises at home in between visits and then maintaining when their sessions are over. I find very challenging. What tips or comments or do you have about that?
Yeah, I think that's a challenge for a physical therapist as well. I try to goal set with the patient. So, certainly I can identify what impairments people have, but I try to relate it of like, what activities are you wanting to get back to? And I think sometimes relating the why behind the exercises and the goals behind it can be helpful. Although I can't control what people do at home, I kind of try to collaborate with them as well. I ask, like, what are some barriers? What do you feel like is challenging about doing these exercises at home? And not asking in a judgmental way, but asking, do you have a safe space to do this? Do you have the time and schedule? And if there's things that they share, that helps me say, oh, it's a time thing. Can we pare down your exercises and do 2 that are the most impactful for you? Or, oh, it's a space, seeing if there are community resources. So I don't have a perfect answer. People are complicated, but I do try to kind of make it patient-centered and go back to what they shared with me at that first visit, like, oh, I want to pick up my grandkids, then trying to bring it into that and make it focus on their goals, but also try to figure out if there are any solutions that I can support with when it comes to some barriers that they feel.
Yeah, thank you. I mean, it is complicated, but I think some of those comments you brought up, really help with that patient-centered care. So our next question, how can patients find a provider in their area?
That's a great question. So there are some and not everyone puts their information, but there is kind of through the American Physical Therapy Association, there's a way for you to search for physical therapists that have identified patient populations that they treat, and it is geographical. Now, of course, that requires the PT to have put in their information in that accreditation, but through the APTA, there is a search that you can see if there's anything therapists in your area. We're in the process of compiling like a list of at least lymphedema therapists in North Carolina, which is a little bit of an undertaking, but trying to compile those lists to share as well. But that's where I typically go. If a patient is traveling really far, I try to go to the APTA website and see if someone is a little bit closer that identifies that they work with cancer patients.
Great. And do patients need a referral to start physical therapy?
It depends. So it depends on their insurance. I think it is helpful to have a referral, and certain insurances require it. However, I have seen people that just self-refer themselves who have more private insurance, but those that have, for example, Medicare, Medicaid, or like managed Medicaid do need referrals, because we have to submit a plan of care and get approval for visits through those. But a lot of times private insurances don't require a referral. So it depends on their insurance. I think a referral is helpful, but I have seen people that don't have them and just self-refer.
Great. So thank you, Sarah, again, for taking the time to answer those questions. Thank you to our audience. Thank you to the University Cancer Research Fund, to the Lineberger Comprehensive Cancer Center, and the Lineberger Cancer Network. Thank you to our amazing telehealth team who is behind the scenes making all the magic happen. So thank you, Tim, Benny, John, Oliver, Andrew, Patrick, Lindsay, and Barbara.